All right, thanks everyone. We'll now reconvene the ACIP meeting, and we will move on to the next session for the afternoon on the East Coast, which is on Zoster vaccines. Dr. Camille Cotton, chair of the work group, will provide an introduction and overview of today's Zoster session. Dr. Cotton.
Good afternoon, everyone. Is someone putting up slides? Thank you. Next slide, please. So here is a list of the Zoster working group, and I'm very appreciative to everyone as we have had excellent conversations and a lot of really robust contributions from the group. Next slide, please. As you can see here, this is the timeline of recombinant Zoster vaccine. I've gone over this previously, so I won't elaborate further, but this is just helpful to think about where we've come since October 2017 until present. Next slide, please. The policy question we have before us today is, should adults aged 19 and over who will be immunodeficient or immunosuppressed due to disease or therapy be recommended to receive 2 doses of recombinant Zoster vaccine for the prevention of herpes zoster and its complications? This would be including but not limited to the following populations, including stem cell transplant recipients, patients with hematologic malignancies, kidney or other solid organ transplant recipients, those with solid tumor malignancies, people living with HIV, and then patients with primary immunodeficiencies, autoimmune and inflammatory conditions, and those taking immunosuppressive medications or therapies. Next slide, please. The PICO question, as you can see here, is the population is defined as immunocompromised adults at least 19 years of age. The intervention is recombinant Zoster vaccine with 2 doses at least 4 weeks apart. The comparison group is no vaccine. Critical outcomes were herpes zoster or serious adverse events, and important outcomes included postherpetic neuralgia, herpes zoster-related hospitalization, immune-mediated disease, reactogenicity, graft versus host disease, and graft rejection. Next slide, please. At the meeting last month, we discussed the economics of vaccinating this population against zoster in the United States, and we reviewed the preliminary evidence to recommendation regarding the use of zoster in immunocompromised adults at least 19 years of age with the standard ETR framework as per the right. Next slide, please. We had subsequently had 2 work group meetings and reviewed and discussed the feedback that we got from the last meeting, as well as the evidence to recommendation updates, considerations for use of Zoster vaccine in immunocompromised adults, and proposed policy options, and we will elaborate on all of that in the upcoming presentations. Next slide, please. So, yes, we will further discuss the interpretation of the ETR regarding this vaccine in immunocompromised adults, considerations for use and policy options. And we look forward to a robust discussion on this topic with a vote later in the meeting. Next slide, please. I'd like to acknowledge the incredible work by the working group, and especially the Zoster CDC lead, Tara Anderson, who's done an amazing job with this, as well as many other collaborators and contributors from the CDC as listed here. Thanks to everyone for their contributions. Thank you.
Thank you, Dr. Cotton. And we'll move on to Dr. Anderson.
Great. Thank you, Dr. Lee, and thank you, Dr. Cotton, for that introduction. I will now summarize the work group's interpretation of the evidence to recommendations framework for use of recombinant Zoster vaccine in immunocompromised adults, considerations for use, and proposed policy options. As Dr. Cotton just reviewed, here's our policy question, and these are the immunocompromised populations addressed. Of note, as she mentioned, this is including but not limited to the immunocompromised groups that were previously discussed with the ACIP. The components of the evidence to recommendations or ETR framework PICO question are also shown on this slide and were just reviewed by Dr. Cotton. During today's session, I will summarize the available evidence and workgroup determination for each ETR domain. First, a review of the public health problem. For this domain, the workgroup was to assess if herpes zoster in immunocompromised adults is of public health importance. As previously discussed, millions of persons in the United States are immunocompromised. In the 2013 National Health Interview Survey, approximately 7 million adults self-reported immunosuppressed status. The prevalence varied by age, as you can see in the figure on the right, ranging from 1.6% for those 18 to 39 years to 4.4% among those aged 50 to 59 years, with an overall total of 2.7%. There are an estimated 3 million among stem cell transplant recipients, patients with hematologic malignancies, renal or solid organ transplant recipients, patients with solid tumor malignancies, and people living with HIV. In addition to these groups, there are an estimated 22 million with more than 80 diverse autoimmune and/or inflammatory conditions, such as systemic lupus erythematosus, rheumatoid arthritis, and inflammatory bowel disease. These patients often have underlying immune defects, but generally are not considered frankly immunocompromised unless they are on immunosuppressing treatments. Importantly, an increasing proportion of immunocompromised patients are likely to be treated with immunosuppressive medications and therapies. The age-specific prevalence of these conditions is highly variable by condition. Herpes zoster is common in the general population. There were approximately 1 million cases of zoster per year in the United States during the pre-herpes zoster vaccine era. And as you can see in this figure, zoster rates increase with age, with incidence rates ranging from about 2 to 9 per 1,000 persons. As previously noted, the immunocompromised population at higher risk for zoster is substantial. A systematic literature review regarding the risk of zoster in groups 1 through 5 noted that the median zoster incidence estimates for these immunocompromised groups exceeded those reported for immunocompetent adults 50 years and older, and this is depicted in the figure on the right. The incidence rate of zoster ranged between 9 and 95 per 1,000 person years. As you can see, there was variation in study estimates for the cumulative incidence and the incidence of zoster within each group and between groups. In the systematic review, it was also noted that zoster complications and severe disease were increased in immunocompromised populations. However, the data were insufficient to assess risk by group. Regarding available data, for postherpetic neuralgia, or PHN, approximately 6 to 10% of immunocompromised patients experience PHN versus about 4% overall in administrative claims databases. And between 6 and 45% experience PHN across immunocompromising conditions and studies. For disseminated zoster, approximately 3% of immunocompromised patients experience disseminated zoster, but it is exceedingly uncommon in healthy persons. And between 10 and 17% mortality has been associated with disseminated zoster among renal transplant recipients. Finally, 8% of stem cell transplant recipients with zoster are hospitalized versus less than about 1% of overall Medicare beneficiaries with zoster. Regarding the risk of zoster in Group 6, included here is a figure and brief summary of findings from a study evaluating the risk of zoster in autoimmune and inflammatory conditions. In this study, the authors determined that there's an approximately 2 to 4-fold higher risk of zoster in patients with autoimmune and inflammatory conditions than in healthy individuals. It was noted that the risks varied across conditions and by age groups, and age-standardized zoster incidence rates varied, with the highest rates in patients with systemic lupus erythematosus, inflammatory bowel disease, and rheumatoid arthritis. Another recent study identified similar results, with an approximately 1.5-fold higher risk of zoster for unvaccinated Medicare beneficiaries with autoimmune conditions versus those who were not immunocompromised. As you can see in the figure on the right from this study of autoimmune conditions and inflammatory diseases, age-specific incident rates among some 21 to 50-year-olds can be comparable to, as noted in yellow, or substantially higher than, as noted in red, corresponding rates in healthy adults greater than 60 years of age, particularly patients with systemic lupus erythematosus, inflammatory bowel disease, and rheumatoid arthritis. The impact of immunosuppressive therapies is another consideration for these patients. The standard of care is for patients to be on one or more immunocompromising therapies, the duration of which could be for months, years, or lifelong. In addition, it is not possible to define high-risk subgroups based on anticipated therapies, since treatments are very different from condition to condition, and even over time for individual patients based on their response, tolerability, and other factors. In summary, important points from work group discussions include that immunocompromised populations are very heterogeneous, both across and within groups and among individuals over time. The risk of zoster and its complications is generally higher in immunocompromised populations, although there is variability across and within groups. It's not feasible to define every possible immunocompromising condition and medication or therapy combination, and that it is important to consider broad recommendations and provider guidance for immunocompromised populations. The work group extensively reviewed these and other findings and concluded that yes, zoster and its complications in immunocompromised adults is of public health importance. Now moving on to benefits and harms. We will review the available evidence regarding how substantial the desirable and undesirable anticipated effects of RZV in immunocompromised adults are for each main outcome, and we will then summarize the work group's interpretation regarding whether the desirable effects outweigh the undesirable effects. Here we provide the information sources and inclusion and exclusion criteria used for the systematic review. I will not go into this in full detail, but the slide is included for your reference. This flow diagram shows the evidence retrieval for all records included in our evidence synthesis. I will not go into this in full detail, but this slide is also included for your reference. There were a total of 19 studies included in our evidence synthesis. Here you can see the 9 studies that were included in the review of evidence and grade analysis, since they included a comparator group. There were 7 randomized controlled trials and 2 cohort studies across several immunocompromised populations, including patients with hematologic malignancies, renal transplant recipients, solid tumor patients, autologous hematopoietic stem cell transplant recipients, patients living with HIV, patients with immune-mediated diseases, patients with inflammatory bowel disease, and Medicare beneficiaries with autoimmune and immunocompromised conditions. Here we list the outcomes included in the overall grade analysis. The highlighted rows are the critical outcomes that will be reviewed during today's session, including herpes zoster and serious adverse events, or SAEs. The important outcomes are addressed in supplemental slides. For outcome 1, herpes zoster, using the efficacy population based on 5 studies, the vaccine effectiveness estimates ranged from 68% to 100%. Estimates were generally higher in young adults within a population and lower for autologous hematopoietic stem cell transplant recipients. There are 2 peer-reviewed cohort studies, as shown here, with VE reported for Izureta et al. Among autoimmune and immunocompromised Medicare beneficiaries of 68% and 64.1% respectively. Khan et al. Looked at VA patients with inflammatory bowel disease and found adjusted hazard ratios of 0.41 for those over 60 years who were non-steroid users and 0.34 for those who were steroid users, and a hazard ratio of 0 for the 50 to 60-year-old group since no cases were reported. Using the efficacy population for studies reporting immunogenicity, this table shows the vaccine response rate for both humoral and cell-mediated immunity across the 6 included randomized controlled trials. These studies show that there was a vaccine response. Starting with humoral immunity, response rates ranged from a low of 65.4% to a high of 96.2% at 1 month after the last dose. This somewhat decreased at the 12-month evaluation mark, with response rates ranging from a low of 51.5% to a high of 91.7%. For cell-mediated immunity, the response rates range from a low of 50% to a high of 93% at 1 month after the last dose, decreasing to a low of 17.6% and a high of 66.7% at 12 months after the last dose. Here's the grade evidence table for outcome 1, herpes zoster. For the RCTs, the evidence type started at 1. There was no serious risk of bias identified and no concerns for inconsistency or imprecision. The body of evidence was downgraded for indirectness due to not comprising data on all relevant populations under the recommendation. The VE estimates ranged from 68.2% to 90.5%, with an overall certainty of type 2 or moderate certainty. For RCTs containing immunogenicity data, the risk of bias was not serious and there were no concerns with inconsistency or imprecision. However, the body of evidence was doubly downgraded for indirectness due to both studies not comprising the range of populations under consideration for the outcome and also that immunogenicity is a surrogate outcome. This evidence was graded type 3 or low certainty. For the cohort data, the evidence starts at type 3. There were no serious concerns with risk of bias, inconsistency, or imprecision, but the studies were downgraded due to the indirectness and upgraded due to a strong association observed among those over 50 years of age. The evidence was graded type 3 or low certainty. For outcome 4, serious adverse events, 7 randomized studies evaluated multiple immunocompromised populations. Overall, SAEs were balanced between the vaccine and placebo groups. Using the harms population, or those who received at least 1 dose of RZV, there was a risk ratio of SAEs ranging from 0.79 to 1.99. It is important to note that this population is significantly ill, and thus the high proportion of SAEs in both the vaccine and placebo group are not unexpected. However, the SAEs related to vaccination were much less common, ranging from 0.33 to 1.6% in the vaccine group and 0.36 to 0.76 in the placebo group. The grade evidence table for outcome 4, serious adverse events, is shown here. The evidence type started at 1, and the body of evidence was downgraded only for indirectness. The proportions of RZV and placebo recipients experiencing an SAE are noted in the table, with risk ratios ranging from 0.79 to 1.99, but generally representing a similar proportion of SAEs in both groups. This body of evidence was graded with a certainty of type 2, or moderate certainty. I will now briefly summarize the grade results, going through each outcome and major findings. The details for the important outcomes are available in the supplemental slides for your reference. For benefits, the body of evidence shows relatively high vaccine effectiveness across these heterogeneous immunocompromised populations, ranging from 68.2 to 90.5%. For post-herpetic neuralgia and Zoster-related hospitalization, there was little evidence, just 1 study, but reported VE was 89% and 85% respectively. For harms, serious adverse events were common and balanced in both vaccine and placebo groups, with risk ratios ranging from 0.79 to 1.99, and SAEs attributed to vaccination were rare. Immune-mediated disease were not shown to be increased for those in the RZV group. There was little data on graft versus host disease and graft rejection, with 1 RCT each showing no increased risk of rejection. Finally, for reactogenicity, RZV was noted to be reactogenic with increased reported local and systemic reactions in the RZV group. Limited data for some harms outcomes highlights the need for additional research as well as provider counseling, for example, regarding appropriate timing of vaccination for some immunocompromised patients. Post-marketing surveillance will be critical to detect any rare serious adverse events which were not identified in the clinical trials. Okay, so upon review of these data, the work group concluded that the desirable anticipated effects of RZV in immunocompromised adults are large, and that the undesirable anticipated effects of RZV are small. Overall, the work group concluded that the desirable effects outweigh the undesirable effects, which favors the intervention of RZV 2 doses at least 4 weeks apart. Okay, now on to values. First, do immunocompromised adults feel that the desirable effects of RZV are large relative to the undesirable effects? And then, is there important uncertainty about or variability in how much immunocompromised adults value the main outcomes? There are limited data on knowledge, attitudes, and practices, or CAP, among immunocompromised patients regarding potential use of RZV for the prevention of Zoster and its complications. In general, Zoster vaccination, including with Zoster Vaccine Live or ZVL, and RZV is increasing, and RZV series completion rates are high by 6 to 12 months after the first dose. Although there is currently no ACIP recommendation, immunocompromised patients recognize the increased risk of Zoster, and many have already received RZV, as noted in a large study of Medicare data where nearly 1 million patients met the study definitions of autoimmune and immunocompromised and received RZV. Concerns related to grade 3 reactions may discourage some immunocompromised patients from getting RZV. In summary, many immunocompromised patients desire the ability to receive RZV to prevent Zoster and its complications. In fact, many are already pursuing vaccination with RZV as part of regular care, as shown in the Izziaretta et al. Medicare analysis. The ACIP Zoster work group placed high value on the prevention of Zoster and its complications in immunocompromised adults. And given the burden of Zoster and its complications in these patients, it is anticipated that more immunocompromised patients would pursue vaccination with RZV if recommended by ACIP and their provider. Okay, so upon review of these data, the work group concluded that probably yes, immunocompromised adults feel that the desirable effects of RSV vaccination are large relative to the undesirable effects, and that there is probably not important uncertainty or variability in how much immunocompromised adults value the main outcomes. Now moving on to acceptability. Specifically, is vaccination with RSV acceptable to key stakeholders working with immunocompromised adults? Primary care physicians' perspectives were captured in a recent University of Colorado Denver CAP survey. The objectives of this survey were to assess among primary care physicians serving adults regarding RSV current practices, attitudes, knowledge, and barriers to recommending RSV, and the likelihood of recommending RSV to immunocompromised patients among the physicians who had not previously recommended RSV to these patients. Physicians in existing Vaccine Policy Collaborative Initiative, or VPCI, Sentinel networks were surveyed, and family physician, or FP, and general internist, or GIM, results are combined with any differences highlighted. Regarding physician strength of recommendation for RSV in different types of patients 50 years and older, you can see here that recommendations for healthy adults, adults anticipating a bone marrow or solid organ transplant who are not yet on immunosuppressive therapy, and adults on low-dose methotrexate are consistent with current ACIP recommendations, with 96% to 70% respectively strongly recommending or recommending but not strongly RSV. Regarding patients without an ACIP recommendation, you can see that strength of recommendation for RSV varies considerably by age and health status, with 67% strongly recommending or recommending but not strongly RSV for adults 50 years and older with HIV, to 42% strongly recommending or recommending but not strongly RSV for adults 50 years and older receiving immunosuppressive therapy for a bone marrow or solid organ transplant. Of note, 27 to 42% of respondents noted they defer to a subspecialist for these immunocompromised populations 50 years and older. For adults 18 to 49 years of age with an immunocompromising condition, 31% of respondents noted strongly recommending or recommending but not strongly RSV. Among physicians who had not recommended RSV to immunocompromised patients, the likelihood of recommending RSV to a range of immunocompromised patients 18 years of age and older was very likely for 40 to 48% of respondents and somewhat likely for 23 to 33% of respondents. Since these responses were based on how likely a respondent would be to recommend RSV to a immunocompromised patient within the first 6 months of an approval and without input from a subspecialist, these results highlight the importance of provider guidance for vaccination of immunocompromised patients. In summary, given highly specialized care and the increased zoster risk among immunocompromised patients, the work group noted that vaccination is favored if there are no safety concerns. Although currently available evidence were considered acceptable by the work group, it was noted that additional safety data is a research need. Importantly, despite the lack of recommendation from ACIP, many physicians are recommending RSV to patients with immunocompromising conditions. Of note, physicians need more direction on which patients are eligible for RSV, including a substantial minority who would be unlikely to recommend RSV to various immunocompromised patients, even if it were licensed, recommended, and covered by insurance for them, without input from a subspecialist. In addition, many specialty organizations are recommending RSV for immunocompromised adults. Overall, the work group anticipates that acceptability would increase with FDA approval and ACIP recommendation. Upon review of these data, the work group concluded that yes, use of RSV in immunocompromised adults is acceptable to key stakeholders. Moving on to resource use. Specifically, is RSV in immunocompromised adults a reasonable and efficient allocation of resources? As noted during the September 2021 ACIP meeting, 2 studies conducted by GSK and CDC assessed the economics of vaccinating immunocompromised adults 19 to 49 years of age against zoster in the U.S. Both studies compared vaccination with RSV to no vaccination and focused on individuals receiving hematopoietic stem cell transplants as the base case. In both models, the vaccination strategy was estimated to be cost-saving when compared to the no vaccination strategy. Both models included additional scenarios that focused on other immunocompromising conditions, including individuals with hematologic malignancies, solid organ transplant patients patients living with HIV, breast cancer patients, and other autoimmune and inflammatory conditions. Most of these scenarios found that the vaccination strategy cost per QALY gained ranged from being cost-saving to $99,000. In the CDC model scenario that focused on autoimmune and inflammatory conditions, the cost per QALY gained was estimated to be $208,000. As noted, in the base case hematopoietic stem cell transplant patients, the economic value of RZV appears to be favorable or cost-saving. This is influenced by higher zoster incidence and zoster-related healthcare cost and reasonable VE. For scenarios focused on other immunocompromised patient groups, the economic value of RZV vaccination was less favorable relative to stem cell transplant patients, given their lower risk of zoster, severe outcomes, and lower healthcare costs. Of note, some autoimmune and inflammatory conditions may have the least favorable estimates of RZV use, depending on the underlying risk of zoster, which is often lower for this group. Considering results across the base case and scenarios from both models, the work group determined the estimated economic values to be generally favorable. Given the higher specialized care and resources typically invested for the base case and other immunocompromised populations, the work group did not consider cost-effectiveness assessments to be a main driver for decision-making. Upon review of these data, the work group concluded that yes, use of RZV in immunocompromised adults is a reasonable and efficient allocation of resources. Moving on to equity, specifically what would be the impact of RZV use in immunocompromised adults on health equity. The National Health and Review Survey captures zoster vaccination data, including data for zoster vaccine live and recombinant zoster vaccine. Overall, in 2018, zoster vaccination coverage among adults 50 years and older and 60 years and older was 24.1% and 34.5% respectively. White adults 50 years and older and 60 years and older had higher coverage compared with Blacks, Hispanics, and Asians. In an analysis using 2010 to 2019 NHIS data, in general, race, ethnicity, household income, education level, and health insurance type were significantly associated with receipt of zoster vaccination among adults 65 years and older. The work group anticipates an ACIP recommendation would increase access overall, since the recommendation increases the scope of the population eligible to be vaccinated and ensures coverage under ACA. However, there will likely still be challenges with uptake, given the previously noted race, ethnicity, household income, education level, and insurance disparities, and variability in health insurance coverage and lack of insurance, which may result in out-of-pocket costs for some patients. It will be important to continue monitoring RZV vaccination through the NHIS, including stratifying by health status and race ethnicity. The work group also noted that equity could potentially be monitored at the local level during implementation. Upon review of these data, the work group concluded that health equity would probably be increased. Finally, moving on to feasibility. Specifically, is RZV in immunocompromised adults feasible to implement? RZV is a refrigerator-stable 2-dose vaccine that can be co-administered with other adult vaccinations. The U.S. healthcare system has experience delivering RZV to immunocompetent adults aged 50 years and older. However, various systemic factors challenge the adult vaccination program in the U.S., for example, complicated reimbursement, lower prioritization of adult vaccines, and fragmentation of care. In the previously noted RZV CAP study regarding physician stocking and referring patterns, 47% of respondents indicated that they stock and refer for RZV, while 42% indicated they only refer patients to receive the vaccine. Of 89% of respondents who referred patients to receive RZV at a location outside of their practice, 80% often or always referred to a pharmacy. Respondents indicated it was easier to refer and identified cost, inadequate reimbursement, and not being able to bill Medicare Part D as barriers to stocking the vaccine. Pharmacies have continued to expand vaccination programs, especially for adults, and are already a major provider of RZV. Per the manufacturer, approximately 60 to 65% of RZV is distributed to administered in pharmacies. It is anticipated that identification of immunocompromised patients, for example, based on immunosuppressive medications and self-reported immunosuppression, and standing orders will be concerns in the pharmacy setting. Additionally, some pharmacies may be out of network, potentially resulting in out-of-pocket costs for patients. Identification of immunocompromised patients may be challenging, especially since RZV is delivered in multiple settings. This highlights the need for provider and patient education materials and clinical decision support. Of note, the majority of jurisdictions have lifelong immunization information systems, which can receive adult immunization information. However, many do not receive health status information. Therefore, we anticipate this will increase reliance on other systems, such as EHRs, for decision support. The work group noted that clinical decision support guidance would be helpful and that it will be important to promote best practices and encourage providers to upload and update RZV vaccination information and jurisdiction information systems, immunization information systems. Upon review of these data, the work group concluded that yes, use of RZV in immunocompromised adults is feasible to implement. And now for the overall ETR summary. Regarding the noted ETR domains, the work group determined that herpes zoster in immunocompromised adults is of public health importance. The desirable anticipated effects of RZV use in immunocompromised adults are large, and the undesirable effects are small, which favors the intervention. Immunocompromised adults probably feel the desirable effects of vaccination with RZV are large relative to the undesirable effects, and that there's probably not important uncertainty or variability in how patients value these outcomes. Use of RZV in immunocompromised adults is acceptable to key stakeholders and a reasonable and efficient allocation of resources. Health equity would probably be increased, and the intervention would be feasible to implement. The work group therefore concluded that the desirable consequences of vaccinating immunocompromised adults with RZV clearly outweigh the undesirable consequences in most settings. And a strong majority voted to recommend the intervention, with a minority opinion in favor of shared clinical decision-making. I will now address considerations for use of RZV in immunocompromised adults. In immunocompromised adults, RZV may be used irrespective of prior receipt of varicella vaccine or zoster vaccine live. Regarding the dosing schedule, RZV is typically administered in 2 doses, with the second dose given 2 to 6 months after the first. For individuals who are or will be immunodeficient or immunosuppressed and who would benefit from a shorter vaccination schedule, the second dose can be administered 1 to 2 months after the first. As noted in CDC's General Best Practices Guidelines for Immunization, RZV can be co-administered with other adult vaccines at different anatomic sites. Providers should counsel patients about expected systemic and local reactogenicity before vaccination. As previously noted, timing of vaccination will be particularly important for some immunocompromised patients. If appropriate, patients should be vaccinated prior to immunosuppression. Otherwise, providers should consider timing vaccination when the immune response is likely to be most robust. Of note, RZV may be administered while patients are taking antivirals. And overall, the work group noted that providers don't want to miss the opportunity to vaccinate immunocompromised patients. Regarding special populations, persons with a history of zoster should receive RZV. If an individual is experiencing an acute episode of zoster, vaccination should be delayed until symptoms abate. Regarding pregnancy, there is currently no ACIP recommendation for RZV use in pregnancy. Therefore, providers should consider delaying RZV until after pregnancy. However, there is no recommendation for pregnancy testing prior to vaccination. Regarding breastfeeding, CDC's General Best Practices for Immunization advise that recombinant vaccines, such as RZV, pose no risk for mothers who are breastfeeding or their infants. Therefore, clinicians may consider vaccination without regard to breastfeeding status if RZV is otherwise indicated. Regarding persons with no documented history of varicella or varicella vaccination, for laboratory testing, commercial IgG ELISAs can be used to assess varicella zoster virus, or VZV, seroconversion after wild-type infection, but sensitivity and specificity can vary. Further, no commercially available assays are sensitive and specific enough to reliably detect vaccine seroconversion. It's important to note that RZV is not indicated for prevention of primary varicella infection, and varicella vaccine is contraindicated for many immunocompromised patients. Persons born in the U.S. prior to 1980 are considered immune to varicella. However, this criterion does not apply to immunocompromised persons. For persons born in the U.S. after 1980 and immunocompromised persons, it's recommended to refer to the ACIP varicella vaccine recommendations. Finally, safety data regarding use of RZV in VZV naive persons is limited. Now moving on to proposed policy options and our discussion. The draft recommendation proposed by the herpes zoster work group is 2 doses of recombinant zoster vaccine are recommended for adults aged 19 years and older who are or will be immunodeficient or immunosuppressed due to disease or therapy for the prevention of herpes zoster and its complications. I would like to acknowledge the many CDC staff, herpes zoster work group members, grade consultants, and University of Colorado Denver Vaccine Policy Collaborative Initiative staff for their contributions to this work. And thank you for your time and attention, and I'll now turn things back over to Dr. Lee for our discussion.
Thank you, Dr. Anderson. And this session is now open for questions, discussion, comments. Ms. McNally.
Thank you. Is there any clinical guidance for co-administration with adjuvanted flu vaccine?
Yes, it's considered acceptable to administer, to co-administer the vaccines, and as noted, just in different anatomic locations.
So we are monitoring safety of that, correct?
Yes.
Do you know when we'll have an update?
There's no safety update at this time, but it is being monitored. Yes.
Thank you.
Thank you.
Any additional questions from ACIP members? In the meantime, I'll ask Dr. Goldman.
Thank you. Excellent, incredible presentation. Really well thought out. I have 2 comments and a question. First, I really appreciate from the primary care perspective this recommendation, because there are still some specialists out there who are not recommending the vaccine in those who are immunocompromised even after age 50. So I think this kind of legitimizes and supports the use of it. So it's really very helpful. The other issue, and I'm glad you touched upon it, regarding Medicare Part D and why vaccinating at a younger age is important, and the issue of many patients not having Part D coverage. So vaccinating before the age of 65 is really quite helpful in getting them covered, as after 65, many physicians are not allowed to vaccinate their patients because of congressional rules and Part D coverage, but that's out of the scope of ACIP. But my question, and you touched on it somewhat, regarding those who have a vaccine status unknown or with varicella, to consult those guidelines. Can you touch upon what would happen if, in this case, someone had their antibodies checked for whatever reason, they're laboratory negative for varicella, but they meet the criteria for immunocompromised? Would you go ahead and do if this passes, give them the recombinant vaccine in that case? But if they're immunocompromised, you couldn't give them the live varicella vaccine. So I'm hopeful that with the clinical guidance, we can get some clarification for those very specific populations who do have a negative varicella assay but are immunocompromised, and how we would approach that vaccination. Thank you.
Yes, thank you very much for your comments and for your question. That question has definitely been a topic of discussion among the work group members. It is a challenging situation because, as we noted here, the available commercial assays make this a challenging topic because of the fact that commercial assays can typically detect wild-type infection. However, the sensitivity and specificity of those can vary, and then the reality that commercially available assays, that none of them are sensitive and specific enough to reliably detect vaccine seroconversion. And then, as you noted, the reality that RZV is not indicated for prevention of primary varicella, but and then the vaccine is often going to be contraindicated for many immunocompromised patients. So this is definitely something that the work group is discussing, and we will be including this in the policy note, and we'll be fleshing this out a bit more in the clinical considerations. But this is certainly an area where there's limited safety data regarding the use of the vaccine in people who are vis-a-vis naive, and there's the challenge for someone who's seronegative and being able to truly confirm that they're truly naive.
Thank you. Dr. Paling.
Hi, this is Kathy Paling. First of all, Dr. Anderson, thank you for a very clear presentation on a very important topic. And the comment I wanted to make is, if I understood correctly, 60 to 65% of recombinant Zoster vaccine is distributed through pharmacies. And if that's true, this really highlights the importance of making sure information flows between pharmacies and providers very clearly, so all are aware of what the vaccine status is. And it highlights the importance of having a universal adult immunization registry that all can see, because that will be important so everybody, including the patients, knows what they've received. Over. Thank you.
Thank you for your comment. Yes, we agree. It's a very important point, and we look forward to having more guidance for that space. It's certainly something that will be worked on between now and when the policy note is available.
Dr. Dries?
Yes, thank you. This issue comes up frequently in healthcare workers as well, where we have healthcare workers who were born before 1980. They're considered immune if they were normal citizens, but they're not because they're healthcare workers. But now they're 50 or older, and they're tested and they're antibody negative, but they tell you they have a clinical history of chickenpox, but they have no documentation of that because it was so long ago. So, the recommendations right now are to vaccinate them with varicella vaccine, but then they also qualify for recombinant varicella vaccine, but it's not clear at what interval they should have that, or can we just go to recombinant vaccine given that they have a clinical history of chickenpox? So it's a common clinical dilemma that would be nice to have some additional clarification on. Thank you.
Yes, thank you for that comment. That is something that we intend to address in the clinical considerations.
Thank you. Dr. Anderson, would you mind putting up the proposed vote recommendation from the work group? And happy to take any additional questions or clarifications that our work group, our ACIP members wish. Well, it was a very clear presentation since it's very quiet out there. What I'll do is I'll actually ask, Dr. Alt, go ahead. And actually, Dr. Alt, while you're making your comment, I think if you could also just comment on your consideration of the proposed draft recommendation above and whether or not you agree with this particular recommendation for a vote.
I agree with the recommendation. I actually move that we accept the language if that's appropriate at this time.
I will take that motion under consideration. Thank you. Any other comments? All right, Dr. Paling.
I would like to second that motion.
Okay, that's terrific. So we have the proposed draft recommendation listed on the slide here has been, it's been moved and seconded that we move that forward. I want to make sure that we open this up for a discussion and make sure that we've answered any questions that the ACIP members have about this particular proposed recommendation. All right, seeing no questions or hands raised in our meeting, I am happy for us to, I suppose, yeah, we can take another break. Maybe Dr. Cotton, is there any other comments you'd like to make to wrap up this session?
No, I think that this will take a lot of education and really robust clinical guidance so that clinicians in the field understand in whom this is best indicated. I think there's often confusion between varicella and zoster vaccines, and so I think that we will have to provide appropriate support. But otherwise, as someone who takes care of many immunocompromised patients and have seen many patients use this off-label or pay for this out of pocket, I do think that this will really enhance the protection of immunocompromised people against zoster. Thanks a lot to the working group for all of their efforts, and especially to Tara Anderson.
Okay, thanks very much. And with that, I'm going to suggest that we break until 17 minutes after the hour. So we'll take a 15-minute break now, and then we'll reconvene for the next session. Thanks, everyone.